if you don't have pain, your feet are fine.
Absolutely false. Those are the most tragic cases when patients can't feel.
Foot infections and diabetes always lead to amputations.
I would be out of a job if that was true. We can do what we call limb saving, limb salvage, limb preservation surgeries where we don't have to end up with an amputation. So Jay came to me as a second opinion because three other surgeons told him he needed a leg amputation. The first thing to easily look at is your shoe. Is it time for an upgrade? We take so much care in our hair, in our face, washing our
Mhm.
hands that we don't think twice about our feet.
Hi, everyone. Welcome back to our channel. This is Dr. Chhaya Makhija, and I'm thrilled to have Dr. T with us today, who is joining us in our mission of empowering you and taking charge of your health in prevention in diabetes, as well as bone health. Dr. T is a podiatric surgeon residing in California. She has an amazing direct care practice in Santa Cruz, and she provides care to everyone in California. I have known Dr. T for a while and also have been at her in her podcast, which is enlightening for all us, for all physicians around the nation. Dr. T, welcome and thank you so much for being here. If you wanted to add a few words of wisdom before we start about empowering patients about just prevention, and then we'll talk about specific topics.
This is a fantastic topic. Thank you so much for having me here. When I trained as a podiatrist, it's 4 years of podiatry school, 3 years of surgical residency. I did an additional elective fellowship year. So that's 8 years of education on how to take care of a patient's foot and
Mhm.
ankle. So we had this very, I would say, tunnel vision type of way to take care of patients, right? Something's broken, let's put it back together. Something's
Mhm.
not right. We talk about prescriptions and things. But the one thing that we rarely ever touched on was
Mhm.
lifestyle, was
Mhm.
things that could create more of an impact. And it wasn't until a few years ago I realized when we're consumed in the healthcare system that we have right now,
Mhm.
we are so limited with time with our patients that we could only tell them a few things. And it had to be like top topics. Like you've got pain, well, there's a drug for that, there's an injection for that, there's a surgery for that. But we
Right.
always skipped over the most practical information. So I'm really grateful to be here with you to share some of the insights I have on how I'm trying to change the paradigm of medicine as to not be so reactive, but we can be a lot more
Mhm.
proactive so
Mhm.
that we don't have to go after unnecessary surgery.
Absolutely. And this coming from a surgeon, I feel like patients will connect to that a lot because it's usually if I see a surgeon, oh, it's going to be surgery, it's going to be using the knife again. But you talking about lifestyle and prevention, it just means so much in terms of helping them to take charge of their health. So I have a few rapid fire questions relevant to your expertise, Dr. T. And you could, comment yes, no, true, false, or just give us one-liners about why it is true or false. So your first one is, if you don't have pain, your feet are fine.
Absolutely false. We know that people who don't have feeling in their feet don't know they have an infection, don't know they stepped on something, don't know that they're going to experience a problem like an amputation. So those are the most tragic cases when patients can't feel.
Mhm.
So not having feeling or pain does not mean you do not need to see a podiatrist.
Thank you. Second one is, all calluses are harmless and don't need attention. True or false?
Anything that's so black and white, you have to assume that it's false. There are
Hmm.
instances where calluses are helpful because it's your body trying to protect itself from a high pressure point. But when it gets too thick or it mimics something else like a wart or even a skin cancer that doesn't have a color, we really do need to have it evaluated to make sure there's nothing underlying underneath that callus.
That's very insightful because you said calluses are also protective. Number three, foot infections and diabetes always lead to amputations.
I would be out of a job if that was true. Absolutely not. If we can catch them early enough, we can protect them. We can do what we call limb saving, limb salvage, limb preservation surgeries where we don't have to end up with an amputation.
Hmm. Thank you. Number four is if I'm already seeing a primary care doctor, I don't need a podiatrist.
This totally depends on the skill set of the primary care doctor. We have some very skilled primary care doctors who can take care of a patient from head to the toes.
Hmm.
But depending on the circumstances, if their education is limited or they really just want to outsource to an expert, we are a great partnership.
Hmm. That's collaborative care. You touched a great point here. Number five is foot ulcers can be treated at home with over the counter creams.
That hurts my feelings. No.
I'm sure that hurts the
It,
patient too. Yes.
because it could be so dangerous. Not all wounds are the same. And I don't know where it came from, but people coming in soaking their feet in apple cider
Mhm.
vinegar and bleach solution. And all of these homemade things can actually make the situation worse and you're delaying care. And you definitely don't want to do that if you're diabetic.
Mhm. Absolutely, absolutely. So now we're going to dive into very, very relevant questions, and I want everyone to, stay tuned because we're not just going to talk about diabetes or diabetes foot, but so much about just taking care of our feet as they are the foundations, of just our musculoskeletal being, as well as standing, running, jogging, and just being on this earth. So our first question for you, Dr. T, is if you can share a story, specifically a patient story, anything that's powerful, someone who's lived with diabetes, where any form of podiatry intervention made a real difference in preventing complication or even improving their quality of life.
These stories come frequently because, people who have diabetes don't know consequences of things until it happens. So I have this
Mhm.
gentleman, I'll call him Jay for now. He was my first patient as I was transitioning out of the insurance model into direct care. So Jay came to me as a second opinion because three other surgeons told him he needed a leg amputation. He was a man in his late 70s at the time, and he did not trust the system.
Mhm.
He felt like nobody was listening to him. He felt like all of the doctors just wanted him to cut his leg. Despite showing up with scars on his legs, which is dry scabbing that could look like gangrene, dry skin tissue, it went from his toes, in between the toes. He had some non-healing wounds on the back of his heel
Mhm.
into the Achilles tendon. So just describing that picture, many can justify that is probably going to end up with a leg amputation because we're dealing with age, we're dealing with circulation problem. He also had a history of diabetes. He was a longtime smoker. So he had a lot of things stacked against him.
Mhm.
And then I realized that if I really wanted to be able to do limb saving, preserving types of procedures, I really needed to earn his trust,
Mhm.
which takes time. You can't do that in a 7-minute visit. It's not black and white. Patients don't come in with one thing or another, right? We have to really look at them as a whole person. And
Mhm.
even though the practicality of amputating a leg is financially more feasible, it's less costly on the system. For that individual, that's his livelihood. So we really need to look at what his needs were and can we actually help them?
Mhm.
So we met him where he was at. And eventually, I was able to get him from a very chronic state into something that was a little bit more manageable. So each and every visit, he saw progress with wound care, with physician coaching was what he really needed to hear and understand, and to
Mhm.
realize that I was there for him.
So, what was the final outcome for Jay?
After 5 years of taking care of him, we've got him from a leg that was going to be amputated to something that got to heal. He only ended up losing part of his, we call it transmetatarsal amputation, because after you lose your first toe and your second toe, you don't have a very balanced foot. The
Mhm.
remaining toes end up getting re-ulcerated and things like that. I was able to maintain a functional level,
Mhm.
and he was able to stand on both feet until his last dying day. And
Mhm.
so it wasn't until his passing, his family shared with me that he was so deathly afraid of an amputation because he had an uncle in his past who had an amputation. So he grew up understanding and fearing that lifestyle. And so he was very adamant, very scared when he first came to see me. But over time, we were able to work through it together and give him a functional limb that allowed him his independence.
Yeah, yeah, that's impressive. That's transformation for the patient too. And we can't even count, like we can't even see the compound um, dollars that were saved by saving his foot and his mobility and him being independent, not being on crutches. So that's mind blowing. Thank you. Our next question would also be pertaining to diabetes. Now, this is what I commonly see because it's foot ulcers, which are one of the most common feared complications in people with diabetes, but also in certain people without diabetes, just like you mentioned about peripheral vascular disease. What are the key strategies as a surgeon that you would recommend both for prevention and early intervention so that they don't deal with this complication?
Diabetic foot ulcers is multifactorial. We've got issues like diabetes that causes nerve damage. So the individual can't feel their feet. So they don't know there's a toy in their shoe, they're walking on it, something sharp. So they develop an open wound. And once a wound on the foot opens, it takes a long time to heal. It's not like a paper cut where it can heal in the next couple of days. This can take at least 6 weeks to heal a tiny little wound on the bottom of the foot. On top of that, we take account aging
Mhm.
or circulation problems that maybe wasn't caught before, but now it all kind of comes together. And then dietary issues, nutritional deficiencies, excuse me, malabsorption issues, gut issues. We compound all of these problems that make the situation worse. And the ulcer might have just been a symptom of something underlying underneath. And so when I see a foot ulcer, I'm not automatically going to let's heal this ulcer with external things. We have to look head to toe. We have to see what made this situation happen today because it was more than likely a series of years that created the right circumstances to
Mhm.
develop a foot ulcer. And so that's the holistic way to look at it. The most beneficial way to deal with this, or the most preventive thing that you can do, whether you're a patient or you're a referring doctor, is to get eyes on them by a podiatrist because a
Mhm.
podiatrist can look at things that we often miss. Maybe it's a structural abnormality, maybe it's fat pad diminishing on the bottom of your feet. Maybe it is an inflexibility issue. The Achilles tendon gets tight. We increase pressures in different parts of the body. Biomechanically, we're looking from the hip down and seeing if there are influences. We're looking at shoes. A lot of the shoes that are being sold easily accessible are terrible shoes for most
Mhm.
people. And so being proactive like that, getting a screening can prevent an ulcer from developing, or it can help the patient establish care with podiatrists where something shows up one day and they get to be seen right away instead of waiting for months for that first referral.
Mhm. Exactly. So, in general, right, for even as per American Diabetes Association, it's you decide as a primary care physician if the patient needs, a specialist referral that's to a podiatrist. And usually, like you mentioned earlier, primary care physicians, the ones who have the skill, will examine. But I'll tell you what happens in the real sense because many patients tell me that they'll get once a year microfilament testing on their feet, and that's just to see nerve damage, right? But a foot exam, you just mentioned so clearly the concepts of how they're placing their foot, the structural abnormalities, and you also touched points on the hips, like the leveling or how they're walking. So I feel like every patient should be seeing a podiatrist, someone like you who's looking at it holistically, rather than just the nerve damage which happens with uncontrolled diabetes, or in individuals who have cold feet, and we are trying to figure out that okay, is there peripheral vascular disease or impaired circulation in those scenarios. Um, just some thoughts. This is just how our healthcare system is. what would be the best way? Like, say, if you are talking to primary care physicians or healthcare providers, mid-level providers who are taking care of patients with diabetes, what's one of the best ways for them to refer to a podiatrist, or how to find someone like you who's also looking at the entire aspect as a specialist?
The most simplest, the most practical way with our current healthcare structure is to find somebody in network. That's kind of what I like to start with. So if you're a primary care doctor, you're a nurse practitioner, you're somebody who's has an inkling that maybe they need to see a podiatrist, you can just quickly go to Google and search the podiatrist nearest you. Now, I will say not every podiatrist really enjoys this arena of care. And so, just picking up the phone, making relationships with all of your podiatrists to see what their interest is could be very helpful. And for patients, on the other hand, who maybe don't have insurance or they're underinsured or they don't want to wait 7 months to see a specialist, I
Mhm.
have the type of practice where you don't need a referral. It's self pay. So that means you get to be seen as soon as the same day if needed. Fortunately, we have an ecosystem where patients
Mhm.
don't really need to wait. They can either go to their primary care doctor to get evaluated, and we put the fire out real fast with some antibiotic and some, basic care, or
Mhm.
they go to the urgent care center and get access to more medical professionals who might know more. But ultimately, at your fingertips, you've got Google, you've got a search engine, you can look around to see who's nearest you to get that care.
Mhm.
When you have limitations with insurance, like it's too long to see somebody, you can look for cash pay or direct care specialists to get immediate access.
Mhm. Yeah, well said. Yeah, because I have personally signed so many forms just to get patients diabetic shoes, just
Mhm.
because they are still trying to get a network podiatry referral, and just a signature is delayed for months and months to get them the right type of shoes. So thank you for sharing that. With diabetes, right? If we look at just people in general who don't have diabetes, who are just looking for better foot health or good foot health, one of the common symptoms or conditions that I come across, and many physicians do, is plantar fasciitis, which is extremely common in individuals and people in general. So, what are the latest, as well as non-invasive treatments that you're seeing, and how do you counsel your patients when they're coming for the symptoms of plantar fasciitis?
I graduated podiatry school in 2014, and then 3 years of surgical residency. So again, my training was very like, let's fix this. And at the
Mm-hmm.
time, we would cut the plantar fascia when all else failed. So the treatments, standard of care includes protection, which is better shoes, physical therapy, strengthening, lengthening your foot muscles and the attachments, and then a steroid injection, and then lastly, surgery. What we know here today in 2025 is there's a lot of modalities that gets missed or not offered, which are the non-surgical treatments, which I'm so glad you brought up because more often than not, these non-surgical treatments can help prevent or treat the plantar fascia issue. We used to think plantar fasciitis was an inflammatory problem, but we know it's also a degeneration problem, meaning there aren't inflammatory cells, it's actually degrading. And so the
Mm-hmm.
treatment for that is very different, which is also why steroid injections don't work for everybody because it's not inflamed and therefore there's nothing to reduce. Steroid injections can also weaken the fibers. And so we are looking at more regenerative therapies, things like PRP, where we withdraw blood, we splint down the platelets, and then injected into the site. We also have non PRP options, which are more biologics, umbilical tissue, amniotic fluid, that type of material is available off the shelf in conjunctions with adju- adjuvant therapies like
Mm-hmm.
shockwave, laser. So plantar fasciitis is always going to be multimodal, where
Mm-hmm.
we're looking at what caused the weakness. Was it your shoe? Was it your activity level? Was it change in hormones?
Mm-hmm.
Weight, gaining weight? We're looking at all the factors.
Mm-hmm.
And then once we do the easy stuff first, physical therapy, correcting your shoe, teaching you how to better pay attention to your feet, and also excluding other medical conditions like fibromyalgia or rheumatoid arthritis. those sorts of things, other inflammatory conditions, then we can start talking about those regenerative therapies to help regenerate the tissue that is weak or needs some improvement.
Mhm. What would be one or two things or strategies that you would advise for someone who's just getting the beginning of the pain associated with plantar fasciitis? Any tips?
Two things to look at when it comes to heel pain that hurts first thing
Mhm.
in the morning is what happened the day prior or the week prior. Was there an increase in activity? Are your shoes outdated, old, and worn out? Some people think that because the shoe is still intact, that it's still providing cushion, but actually that cushion degrades. So it's kind of like a rubber band that sits in the sun for too long, that elasticity breaks. It's no longer there to support. And so the first thing to easily look at is your shoe. Is it time for an upgrade? Is it time to change it? And then the second thing is YouTube can teach you so much about your whole body and just look up foot strengthening exercises such as short foot to start getting your brain connected to your feet and
Mm,
increasing the strength of your foot muscles so that it doesn't pull and strain on the ligaments. So your muscle really needs to absorb the shock in order for you to have more function on your feet. So
mhm,
two things, shoes and strengthening foot exercises.
mhm. Impressive. Yeah. I have my exercise coach is a runner. And if I complain of either a calf muscle or a shin pain, she's like, "You need new shoes, girl. You've been exercising with me for 2 months. New shoes." So, I so agree with just these common sense tips that you mentioned. Our patients with diabetes, are they at a higher risk of developing plantar fasciitis?
That's a good question, and I don't have a good answer for that. We do know that glycosylation or high levels of blood sugar can cause inflammatory
Hmm.
issues from head to toe. So, even those who may not be diagnosed with diabetes, if they have prolonged periods of sugar in their blood, they can
Hmm.
create a hyper-inflammatory state leading to more pain than usual. So, when it comes to a person who has diabetes for a long time, I think about pain coming in different ways. We describe pain differently. What I
Hmm.
might describe as painful, they might describe as numbness, right? And so there's kind of a mixed signal in how we
Hmm.
perceive or communicate pain. But when a person who has diabetes tells me they have pain, I'm worried more about nerve damage, not
Hmm.
we can do diagnostic. We can look at ultrasound to see if there is thickness and inflammation in the plantar fascia. We can order advanced imaging to see if something else is going on. But if somebody has diabetes and they complain of heel pain, I'm doing a more thorough workup for them.
Hmm. Hmm. Great, great insight. You know what I loved when you touched points on steroid injections, because that's still a norm at many medical offices where there are podiatrists, where the simple is like, oh, just take some NSAIDs, non-steroidal anti-inflammatory agents, not working. Let's just give you a steroid shot around the area affected. But you just gave us like at least five or six non-invasive therapies that could be helpful for plantar fasciitis. So that's very impressive. Um, if if you were, if you were seeing a plethora of cases, right? Where is this foot care at? Like, say, if I had to talk to individuals where I am suggesting, prevention of deformities, prevention of injuries, and just regular foot care. Because we think about hair, we think about our face. We also may think about our muscles, building, going to the gym. But feet are those organs which are neglected the most. Patients even feel embarrassed to untie their shoelaces and show me their feet on certain visits. They're like, oh, you know what? Not today, maybe next time. Right. So if you have, advice for our younger generation, for our younger adults, as to even paying attention to their feet, how and what strategies, what tips, what pearls of wisdom that you would share as to when they're taking care of themselves, feet are an important part of their holistic care.
You're totally right. And people will always say, after the fact. I wish I knew.
Yes.
Or worst case scenario, I get patients who get amputated and they're like, I had no idea, right? So we have to kind of model the dentistry
Mm-hmm.
where in the dental industry, they have really normalized visits with the dentist every 6 months. And that was a huge push for a long, long time. Now, podiatry is a younger profession. We've got long ways to go,
Mm-hmm.
but we have to normalize looking from head to toe. And I've had patients who come to me because they're diabetic. And when I do like a monofilament testing
Mm-hmm.
to test their sensation, I do the 10 spots. The patient says to me, my doctor never did that for me.
Mm-hmm.
So then that makes me ask, then what are they doing? What are they checking for? Are they not checking for? Like, do they not know what to do? Right. And so where's the gap that I can help fill? Overall, like you said, we take so much care in our hair, in our face, washing our hands that we don't think twice about our feet until it hurts.
Mm-hmm.
And that's when I have the opportunity to educate. And so, when patients come in, they're in pain, they just want a quick fix. I have to educate them and say, yeah, I can give you a steroid injection, but then when it comes back, or if you get worse because I weakened that ligament, then what?
Mm-hmm.
Then we have to spend, not 7 minutes, we have to spend 30 minutes to really show them what it looks like to take care of your feet.
Mm-hmm.
And it's not complicated. It's something as simple as making sure your shoe isn't floppy,
Mm-hmm.
making sure that when you walk around, you are activating your foot muscle. Something as simple as walking on different textured ground, just so that your brain maintains a connection with your feet, that you are all connected,
Mm-hmm.
is so subtle, but so important. So just like washing your hands, you got to wash your feet in your shower.
Absolutely. Yes. In terms of mobility, balance, and independence, right? Are there certain things that you would advise any adult, but any tips in their daily routine that you would suggest or recommend as self-care?
Oh, I have a laundry list of self-care, but if we're going to keep it easy, the
Yeah.
easiest thing you can do at the end of the day when you take off your socks and shoes, airing out your feet,
Mm-hmm.
is wearing something like yoga toes or toe separators, something that helps you like stretch out and take notice of your feet. And you wear this thing, it's made of silicone, it's very soft material. You wear this thing for 15 minutes a day at the end of the day, walking around barefoot to stretch and make sure your body understands that your feet is connected.
Mm-hmm.
When we don't pay attention is where it becomes problematic, because I see people in their later years
Mm-hmm.
and they're inflexible. They have these hammer toe deformities, these bunion deformities. It hurts to just manipulate the toes just to cut their toenail. And at
Mm-hmm.
that point, it's either you live with what you have or surgery. So the more flexible you can be with your feet, the more you give them room wearing the right shoe, and just maybe against the status quo, stop wearing pointy-toed shoes, those cowboy
Yes.
boots, those dress shoes, those stilettos, right? Start becoming a rebel just so that you can fight for your body's ability to last you longer through the years.
Hmm. Yeah, so well said. Yeah, I learned actually these tips the way what you're saying is a long time ago, like probably it's been 12 or 13 years with from my yoga teacher as to how to place the foot and why the separation is important. You need to see some air, some space in between your toes and the reasoning behind it. And it also helps with our hip, our pelvic alignment. So that's so interconnected. That's amazing. Is there is there a specific type of shoe that you recommend to patients with diabetes, or do you suggest that they should get a full evaluation and refer or purchase or try to get access to specific medical diabetes shoes? So I'm talking about, are there anything other than prescription diabetes shoes that are available that you would recommend?
When we talk about diabetic shoes, what we're looking for are the following features. We want to make
Mhm.
sure the shoe is thick in the sole where you can't fold it in half, because the thicker the sole, the more distance a nail would have to penetrate before it gets
Mm,
to the foot. And so we want to kind of think about how shoes protect our feet in that way. Another feature of a diabetic shoe is that the toe box is tall so
mhm,
that we can remove and replace an insole should you need a specific one for your
mhm,
foot type. And so that the toes don't get cramped and start developing into a hammer toe, and then you get sores and corns and calluses, which can cause openings and then end up infected. And then the last thing I mentioned was the insole is removable. So we just want space in the shoes. Now, right now, Medicare does have an allowance for Medicare beneficiaries for diabetic shoes. I think it's one every year
mhm.
or every 2 years.
Every
I don't
2 years, I
remember.
think. Yeah.
But what about in between? Because we know shoes don't last that long.
Mhm,
You can look for brands that are called diabetic shoes like OrthoFeet, Anodyne shoes. There are so many out there that have these features that can be very protective. So we're talking about again a thick sole, a removable insert, and a tall toe box, just to name a few.
mhm. Those are, yeah, I love that because those were the few key points that are necessary in the shoes, and I feel like all the patients should be aware of that. It's not just thicker sole, but there are more features that are required in a diabetes shoes. Is it necessary? So this would literally be our last question for diabetes, but is it necessary for an individual to get a prescription based diabetes shoes versus can they start with something just the way you recommended for to start with if they don't have any calluses or any form of specific deformities or any current symptoms?
You can get started with getting protective shoes right away, and it's probably going to be one of the most impactful investment
Hmm.
because you don't want to wait till you have a sore to then realize all of your shoes were trash. Medicare has this program, but who knows how long it's going to last for. We're talking about budget cuts, we're talking about more restrictions. Don't wait for it to get covered.
Hmm.
And there's so many coupons lingering online and so many different associations to be a part of that you can get a really great deal
Hmm.
and be able to protect your feet. I mean, I think even shoes, I don't know what they're costing now, like $150 or so. It may sound like a lot right off the bat, but if you think about $150 spread out over a year,
Hmm.
each day you're spending pennies to protect your feet.
Hmm.
And wouldn't that be so much more worth it than ending up with something like a diabetic infection that lends you to end up in the ER? You
hmm.
may or may not be in the right hands. You may or may not get an amputation, time off of work, the stress of that accrues, and the financial surprises that can come
Hmm.
from that kind of visit is just outweighs the risk and benefits. You really have to look at it head on. Is $150 really that much compared to what could happen if I were to skimp on this very practical thing?
Yeah, absolutely. Uh, this is gold. What you just mentioned about foot health, and I feel like the way you broke it down is just how humans think. Our minds, and that's very important. The way you broke it down, pennies a day, and that's such a key in terms of just protecting our feet and foot health. Absolutely. Great, insightful answers. Dr. T, if an individual who's in California or anyone who wants to be your patient or get expertise from you or a consultation, how can they reach you?
I would really love to help as many people as possible to get the foot health care that they need.
Hmm.
But it does require a little bit of out of box thinking. And so my practice is unique in that you don't need a referral. So if you want to just make a consultation virtually or in person, it's so easy to do that. You go to my website, drtpodiatry.com, and you click on the button that says request a consultation. So if available, there's 15-minute free consultations just to help you figure out and navigate the healthcare system. Whether I'm a right fit for you or not, at least you can walk away with knowing what your options are.
Thank you. And if someone had to follow you on social media, where can we find you?
You can find more free content on Instagram at Dr. T Podiatry.
Okay, thank you so much. Guys, follow her. I do, and I have my patients do the same thing because there's so much education, being outpoured, and this is just for you. So take advantage of all these amazing specialist physicians and their advice, and who knows, you may be able to, save someone else's life or learn from all these important insights from Dr. T today. Thank you so much, Dr. T.
Thank you. It's my pleasure.